Thank you so much. I've just absolutely have loved being with you all for yesterday and last night, and I'm so grateful to be included, invited to start to work with you on the things that you're already working on and that you and your leadership care about. And I also want to do a special shout out to Doctors Gerland and Hahn. The choice of who you invite or where you put your resources and concentration and energy show a lot to us all about what your values are. And so there's lots of other things you could concentrate on. I think the idea that the leadership is really invested in this, in supporting the well-being of all of you doing the work is just a wonderful thing. And it's not a throwaway. It isn't true everywhere, I can tell you. So I don't have any relevant disclosures. I put this bottom line is that I'm biased, just like unconscious bias, like all of us, and I do want to be aware of that. And to say, in my discussion today, or anytime I'm interacting with anybody, if there's something I do or say that doesn't feel right or shows some kind of bias, I would appreciate your letting me know, so I can improve and be aware and do best by all of us. Everything I do, just like you all, is a team sport. And these are just some of the people that I've worked with and continue to work with and learn from around some of these issues. There are many more, but I just always want to acknowledge the team. So I invite you to think of a time when you were really working very hard, let's say patient care, right? Really working very hard, and you felt really supported by the team, your colleagues, even sort of broadly the organization, supported in doing the work that you were trying to do, whether it was in clinical care, administration, research, education, really challenging work, and you felt really supported in doing it. We've all felt that, right? That's an amazing feeling, even if the work is really challenging. That's what we're going for. We're going for that feeling much of the time, instead of like, oh, let me just try to remember when I last felt that way. Okay, so that's sort of our goal. I'm an organizational change warrior. I really like to think about how organizations are functioning, what the culture is, and whether that culture is supporting the work that we're doing or actually undermining it. And I do believe that, if you're really talking about change, you actually have to spend some time looking at the dark side of the culture that you're in. And I'll say that we're in terms of medicine, because if we don't look at that dark side and really face it and work to change it, then the initiatives that we do are probably just going to fall flat, because the culture will run up against the culture. The status quo, as you know, is very powerful. So I'm going to speak a bit about the dark side of the culture of medicine. And I do want to say this, I think you know this, I am not here, I wasn't invited to tell you, look, you guys are really not killing it at all here. And you need some help from somebody who can just tell you exactly what to do and also just show you how bad you're doing. And that's not the case at all. When I talk about the culture of medicine, I'm not talking about, Harvard or Stanford or any one particular place. I'm talking about the culture of medicine that, in my experience, even having the honor of working internationally and all across the US, there's sort of a through line of what the culture of medicine as a profession is like. Even though I love the regional, state, national differences, I think they're wonderful, and I appreciate cultural differences. I have found, and I think you'll agree, knowing people all over the world who do medicine, that there's certain things that they're very common in the culture of the profession of medicine writ large. So that's what I'm talking about when I'm talking about culture for this discussion. So one of the dark sides of the culture of medicine, in my opinion, is this, the kinds of behaviors that I just want you to read this case. I want to confirm that our remote participants are able to see the slides. Yes? Okay, good. By the way, pedagogically, it's better to have people read to themselves than have the speakers read, because there's a dissonance between the speed of those two things. So I'll be doing that at times, okay? All right, so I made this case up, but it didn't come out of thin air. Let me put it that way. And I'm sure I can, be pretty confident that you look at this and you're not like, what, are you kidding me? Oh gosh, too bad she has that at her organization. No, like this is real stuff, right? These are behaviors. I'm obviously going to use cases that are like a little on the more intense side, right? But you all can imagine this is realistic to a degree, and even if it's a little more subtle in different situations. So we've got Dr. D, who's got these specific behaviors that are really problematic, okay? So I think you will agree that in medicine, and I would say, unlike some other professions, in medicine, we have tolerated this type of behavior. We have, right? It was acceptable, it has been acceptable. And in fact, not even just tolerated it, many times people got promoted for having this kind of behavior, right? And so, we have to, if we want to make sure we don't have this behavior, we have to look at, well, what has it been about the behavior that has enabled us to tolerate it? And when I say us, I'm talking about sort of all of us in the sense of people who taught us, people who had leadership positions, and also, to the degree that it's hard to get this behavior to go away. As a leader, if you were in charge of things, right? What kind of rationale do you think you might have, or people around you might have, that would make them reluctant to say to Dr. D, you can't do this anymore. This is not okay. Like, how have we justified the behavior, even though we know it's not great? Right? What are some of the justifications for it? And they're not off the wall. They're like realistic reasons why we have generally tolerated this. So anybody, what are the kinds of, rationalizations, if you will, or I'm going to say sort of excuses for allowing this behavior? Yeah, they're super busy. They do a lot of work RVUs, AKA they bring in money for the organization. Yeah, and we want that. We want that money. We want that productivity. Absolutely. Yes, and sometimes the people who are behaving most like this are the most productive in that way. Thank you. Anything else? Why would it be kind of hard to sit down with Dr. D and say, we can't, no more of this? Yes. Yes. So they have other skills and talents, which we feel offset this. So they may be technically very good, cognitive, really, really smart, and have lots of other good skills that we go, okay, well, this isn't so great, but we'll just tolerate it because the other stuff is so good. Thank you. Anything else? If you had to sit down, or like it was your job to sit down with Dr. D, what would make you really reluctant to want to have that kind of accountability conversation? Yeah, we don't want to really tangle with Dr. D because, and my fantasy, because I've tangled with a lot of them because that was my job when I was at the Brigham to have these conversations, is, my fantasy was like, we would sit down with Dr. D and say, here are the behaviors, here's why they're concerning. And Dr. D would say, Joe, thank you so much for the courage of bringing this to my attention. I will never do it again. We're done with that. That's bad, right? Okay, now sometimes people did own their behavior, but not, the person who behaves this way to others is not likely to say that to you, and especially if you're a leader in accountability, and it's not going to be easy. So, and we may even be afraid that they'll retaliate against us, even if we're in a power position, because they may know people above us, if you will, someone on the board or what have you. And so I think think there's fear of holding somebody like this accountable. Absolutely. So thank you for these are, absolutely some of the reasons I'm going to add a little bit, the fear, as I said. And I think we've got in medicine, just like anywhere, but a lot of tribalism, right? So I used to be responsible. One of my jobs was one of the co-directors for graduate medical education for Mass General Brigham. So I was in charge of the orientation for every single physician coming into the organization, right? And so the one that I led for the interns, what I would say at some point was, hey, you're all here together and it's like so cool. You're like an intern family. And I go, 5 seconds after you leave orientation, you're going to be trash talking other specialties. I mean, I'm married to an internist. I know what they say about us, okay? And so the point is that that tribal behavior, right, does feel good. It makes us, sort of us versus them, and they're just doing, what have you. But it can also lead to sort of othering and this kind of thing, like no one else cares about patients as much as we do. I think that what this was already mentioned, that there's other skills and talents. A lot of us are like, yeah, well, that's kind of how we trained and we turned out okay. Sort of tradition is very tough, to sort of separate from, because we see it has worked to a degree. Of course, we have to understand that it was not really all that successful as we think. I think a big one is we didn't know how negatively this kind of behavior actually affects the outcomes that we really care about. And that's what I'm going to make the case to you, is to show you that, okay? Because if you think the behavior is not causing harm, right, then why bother to say stop doing it? You have to be convinced that it's problematic in a, anything other than a superficial way. Okay. And I don't think we really had that data. We have it now, though, right? We have it now. Okay. And this is a big one, especially, obviously in academics. I didn't have particularly malignant training, but there was some. And I believe that the people who, humiliated us, like say in the operating room, or, were just particularly harsh and disparaging, actually thought that that was making us better, that we'd be better able to handle stress, and this is just sort of this myth that if I'm going to show you how high my expectations are by showing you how poorly you meet them. And I think genuinely people thought that that was a good thing in terms of education. And I, hate to break it to anybody who thinks it's true, is that it doesn't. So this is not about specifically, med ed, but this is a curve about performance, and it mapped against stress. So it's true that if you want people to perform, there has to be some activation energy. And what I would suggest is when we walk in the hospital, we're already kind of at the top of that stress curve, just because the work we do is so high stakes, right? If you stress people more, you push them further, like humiliate them, it's going to degrade performance. Okay, and here's a very specific study on that. That looking at dexterous skill acquisition is facilitated by the absence of strong arousals. That means that if you're getting yelled at or humiliated, or someone's being sarcastic to you as you're trying to learn a skill like this, you're not going to acquire it as readily as if you're, as if your arousal level's a bit less. Okay, it's not going to be zero, like you have to be, but you're already up pretty high. And so adding to that actually interferes with learning. Again, I just don't think educators were aware of this. So this is a little bit of a credibility graph. I just want you to know that I have a tremendous amount of experience in handling and having conversations with people who behave like Dr. D, because it was my job. In the center, was if you had a concern about any physician, intern through senior faculty or APP, regardless of who you were in the organization, secretary, scheduler, pharmacist, senior faculty, whoever, if you have a concern about behavior about a physician, it would come to me directly, right? And so I had a lot of these conversations and a lot of these, having to adjudicate, not alone, but that was my job, is to move forward, understanding what the concerns were. So, kind of over 500 of these individual physicians about whom concern, or APPs about whom concerns were raised. So I have a lot of experience with this. Okay, so I'm going to make the case to you, first of all, what psychological safety is, why it's crucial, and how unprofessional behaviors undermine psychological safety, and then strategies that you might want to consider in your organization, both individually, as teams, and as the organization that actually supports psychological safety. But I do believe first I have to get your buy-in, because you've got a lot on your plate. Leaders have a lot on their plate, and there's constrained resources, and especially about people's time. So if we think this is important, right, it will justify using those resources, including people's time, in order to think about how to support it. So I would like to convince you. Amy Edmondson, she didn't invent the term psychological safety, but she's a researcher at Harvard who's done work researching psychological safety within healthcare teams. Okay, and so this is her. This particular slide comes from her work. What is it? It's a shared belief in interpersonal safety within the team. A sense of confidence that the team will not embarrass, reject, or punish someone for speaking up. And you'll hear this theme of like creating an environment where people can say something, right? Or ask a question, or say, that I have a concern, okay? And it stems from, and this is the most important, mutual respect and trust among team members. Now, when you're sitting here and going forward, I would like you to think broadly about what that team is. Does it include your administrative staff? It should, right? It absolutely should. They're part of the team. It doesn't just have to be those people rounding, okay, or those people in the operating room. So, healthcare is extremely interdependent, and I think we need a broad working definition of what my team is. But I think you'll agree that there is not just automatic mutual respect. That has to be built, and trust, right? And they're easily taken down. So you need to think, if you think it matters, you need to be, not just assume, of course we all respect each other, because I don't think that is intrinsic. Okay. Oh, it did, thanks. Okay, so the other thing I want to encourage you to do is, and this comes from a book, I didn't write it, so please don't judge me, but a book called The No Asshole Rule. And it's written by a Stanford business professor. And it's not about medicine. It's about what in the workplace, the kinds of issues of, I'll say jerks, okay, of letting people roam the halls, behaving in this way. And one of the things that he says is, if you think someone's being a jerk, first look in the mirror and make sure it isn't you. So I don't want you to be thinking here like, oh, we've just got a couple jerks. I would never. And I will tell you that I wasn't allowed to start the Center for Professionalism and Peer Support because I had been crowned Queen of Professionalism at Brigham and Women's Hospital. If I am under-resourced, afraid, time stressed, or whatever, it's hard for me. I can have an edge, right? It's hard for me to maintain my professionalism. It's my job. I still have to do it, but it's hard to do. So I do want to say that we do need to really reflect on our own behaviors, and make sure that we're, in line with what we think is the right thing to do. The other thing is that, statistically speaking, as far as Dr. D, you have just as much chance of being a target of that behavior as you do a bystander. And bystanders have a lot of power, unused sometimes. And I'm just going to show you about that in a minute. So what is professionalism? Not this, right? So when I started the center, I basically was like, I'm not going to spend a year doing a whole, organizational thing of like, what do you think it is? What do you think it is? And there are like almost 6,000 articles on medical professionalism. So I'm like, I'm just going to define it for our organization. And, that was a while ago. I think it still works, right? It's behaviors that support relational trust. Okay. It's not about what your hairstyle is, right? And it has been misused, and people are very wary of that term because it can have a lot of bias to it, et cetera. So I think having a touchstone about, okay, is that thing that you're calling unprofessional, is it truly, like, is it eroding interpersonal trust, relational trust? It's a really good touchstone, being very careful not to overcall things, but also to really recognize when we have behaviors that do undermine relational trust. Okay, so the kinds of behaviors that I'm here to talk about and we looked at and we're trying to deal with and study were these things. And microaggressions are any of those things, but just done in sort of smaller aliquots, right? Which can be over time pretty demeaning and difficult, even if they're not as huge individually. So that's the kind of behaviors we're talking about. So they're rampant. They're still rampant in our healthcare organizations. This is just, I just put up a couple studies here. You don't have to look far to get studies. And looking at this one, with thousands of physicians, nurses, staff, seeing behaviors that correlate negatively with patient safety lapses and patient quality, negative outcomes. Not good. Really not good. It's a known safety risk. I want to tell you that in the paper that we published recently, that I don't want us to sit here and think like this is all doctors behaving badly, right? So in this particular study, and we were only studying interns through senior faculty and APPs, and we asked lots of questions, a survey study about different behaviors. But one of the questions was, if you see unprofessional behavior, what group is more likely to exhibit that unprofessional behavior towards you or others? And every group felt it was the nurses. Okay. Do I think nurses are bad? Absolutely not. I put this up just to say that it's not just one group or another. It isn't. Okay. We're all at risk for behaving this way. And so that, just keep that in mind. So this is, I'm going to show you a study, another study, if with less teamwork measured, right? The patients were at higher risk for death and complications. Those of us who are more senior should just be like our eyeballs falling out, like in amazement, because we didn't know this, right? Nobody thought to, first of all, we didn't even have the 6 competencies. It was like, are you technically good? You're cognitively good? You're in, you're good. We'll reward you. The idea that maybe your behavior towards anyone in the healthcare team might affect your patients, didn't know it, okay? But we do know it. I'm just putting up a couple things. Did you all get the memo? Did you send the memo out here at your healthcare organization that you're done with shame and blame? No, right? Nobody did, right? No organization said, the way that we've reacted to harm events forever, which is shame and blame, we're done with that because it actually undermines safety. We used to think that the way to make the system safer is to find out who did the bad thing and punish them. And it turns out completely undermines safety. So we're now, going for just culture or safety culture, but where the idea is, let's learn from this harm event so it doesn't happen again. But think about it. You can't just go from one embedded decades and decades long culture to another. It just doesn't work that way. So what I'm urging you to do is to think about where you're still doing shame and blame. And I don't mean you personally. Well, personally, right? And organizationally, are you still doing shame and blame? Because it's hard to eradicate if you don't notice that, hey, when we did this M&M or this root cause analysis, it really wasn't done in a learning environment, fashion. It was really framework. It was done in shame and blame. And I just want to show you one study that looked at what happens to female surgeons where they've had a patient death. And it turns out that referrals to that surgeon dropped by 54%, where there was almost no change in referrals to a male surgeon who had a patient death. Okay, this is obviously unconscious bias, but I put it up here because I want this to me, this is an example of unconscious punishment for an event that you may have no idea what happened, or even if there was an error, but what have you. And it's differentially in this particular case gender-based, but I want you to see we judge each other. So that undermines the psychological safety, the safety culture, right, of our organization when things like this happen. And if you look at lots of the processes that happen after harm events, you'll see that sometimes they're done in a way that's more shame and blame. And so that undermines trust in the system, that people aren't here to make me feel horrible about what I did. I mean, there are times when that needs to happen, but mostly these are human errors, and humiliating somebody over them does not make the system safer. So the Joint Commission, this is a study of thousands of errors. The most common cause were communication issues, okay, not technical failures. How much time do we spend on communication within the healthcare team, even though it's one of the most powerful drivers of errors or error prevention? Not much, if you think about the relative amount of time we spend in training and in keeping this like at the top and studying it. So the Joint Commission put out this Sentinel alert in 2008, and they updated it in 2017 to say this: got to stop these behaviors on the part of everybody. This isn't, again, to one group or another. And they define them as behaviors that undermine a culture of safety, okay? A culture where we don't do shame and blame, we don't do punishment. We certainly do personal accountability and systems accountability. It's not like, hey, it's not my fault, no. What could you have done? What could I have done better? What would I like to do going forward on a personal level, and also looking at systems? It's not either or, okay? So this is for everybody. And let me say this. Okay, so whoops, let me go back here 1 second. Okay, when I trained, if an attending surgeon threw an instrument in the operating room, no consequence, really, honestly. It was like, well, it's stressful, what are you going to do? And I think we all understand, like, you can't do that anymore. Okay, we pretty much got that. But what if a majority of times that you're rounding with me, and I say, you ask me a question, or in the OR, you ask me a question, and I turn to you and I go, I'm sorry, did you actually go to medical school, or did you just like walk in off the street? How do you not know that? Okay. Or we're rounding and I go, what antibiotic do you think we should give this patient? And you tell me, and I go, that's perfect, if what you wanted to do is kill my patient. Okay. Am I calling you names? Am I throwing things? Am I raising my voice? Nope. But how likely are you, or is anybody who's witnessed this going to be to ask me a question tomorrow, or give me a piece of information I might need that I'm not seeing to help with patient care? You're not, because nobody wants to be humiliated, right? It's I don't say it's worse than getting, throwing something at you, but it's certainly, yes, it's subtle, but it's very powerful anti-communication, if you will. So the Joint Commission knows that, and they said, let's further define some types of unprofessional behaviors, verbal, physical threats, intimidation, even passive aggressive. You say, every time you say something, I just sort of turn and start talking to someone else. It's not good, right? It's not good. Okay, so just throwing up some statistics here as to other examples of unprofessional behavior, which you would agree harassment is. And just look at this. I actually did teaching recently for the Defense Health Agency, which was a consolidation of all of the military health. And it was for leaders. And I put this slide up, and they literally were like, they could not believe like how bad this is. And we should all be appalled, okay? I do also want to acknowledge that as far as issues around discrimination, that they're worse for intersectional groups where you are a member maybe of an underrepresented minority and woman, those sorts of things that it's additive, if you will. And I want to point that out, because this is a very well studied phenomenon, something we also need to think about. It's just our experience of being in the world and being in a profession is very different if depending on what groups you belong to, if you will. Okay, so let's just very briefly, in my quest to make you inspired to care about this, is okay. How do people who experience these kinds of behaviors fare, right? And remember, this is really important. I have yet to meet anybody, and I've met a lot of very difficult people in my job. That's what I was there for, who walk into the hospital and say, You know, what would be so cool today is maybe I could humiliate a resident and they'll like actually quit surgery. That would really work for me. Or I just think I'm going to make a nurse cry. So fun, right? No, right? Now, that may be the impact of their behavior, but it isn't their intent. But the impact is what counts. So this is just, nothing to do with medicine in particular, but just look at all the ill effects of being bullied, which is just a lay term, well, for intensely unprofessional behavior. Bad stuff, right? We shouldn't allow it. It's really bad. Sexual harassment, look at this impact. It's hugely negative. The fact that it's still around a lot and that we have tolerated it, it's really knowing how bad it is. Let's like wake up and do something about it. It's so important that we deal with this. On the positive side, this is a different study, positive communication and collaboration between attendings and residents. Lower risk adjusted morbidity of patients. Remember, we're measuring something so upstream, having a huge impact on the very outcome that we all walk in to try to get, great patient care. How amazing is that? That's really good that connection has been made. There's a whole science of what's called relational coordination, where you take a big team, like when I say big team, what I mean is with a broad definition of what team is. So you might take us, in one case they studied like an ortho team, including the schedulers, all the front desk people, the APPs, the whatever, everybody related to this procedure, if you will, which was knee replacement. And you can measure the kind of communication amongst different team members, and they study all the different groups, and they come up with scores, but they're measured around these shared goals, shared knowledge, and mutual respect as evidenced by these communication styles, right? Or the communication, not styles, but so much as how are people communicating with each other. Important looking at the problem-solving communication. You can communicate frequently and accurately, but if you're doing it with like, you're running behind, you're running behind, you're running behind, that's not problem-solving. It would be like, you're running behind, what can I do to help? Okay, that kind of way of being with each other, especially during stressful times. And so they found in this, they've done a bunch of studies, a linear correlation between patient outcomes after knee replacement and measuring this relational coordination amongst the broader team. Amazing. Okay, so it's a phenomenal lever that we have to get good care. I love this one. They looked at thousands of supervisory physicians, thousands of physicians, and asked questions about the leadership, the person who supervised them, and found, look at this, for every 1 point increase in leadership scores for domains like respect, dignity, interested in my opinion, there was a 9% increase in satisfaction at work, and a 3.3% decrease in burnout for every 1 point increase on these domains. What if we trained all leaders to lead in this way? Look what a lever that we would have in terms of improving satisfaction and decreasing burnout. Amazing. We know that that higher clinician trust correlates with higher satisfaction, lower stress, and decreased odds of intending to leave. Anybody know how much it costs when a physician leaves a hospital on average? What it costs the organization? Yeah, it's about $500,000, and it's certainly $250,000 anyway, and usually like even more. Don't you think people who control the resources need to know that if we don't support trust within the organization, that we're going to lose people. They're going to leave. People most often do not leave for money. They leave for how they're treated, how much trust there is, how much respect they get. Okay. Okay. Now I want to say this. Medicine's very hierarchical, military is hierarchical, and I'm senior and I love a good hierarchy. Hierarchy's not bad, but it's a hierarchy of responsibility. So what hierarchies are good for is role clarity. I know what my responsibility is. You know what yours is. You know what yours is, right? That's a good thing. I am not advocating we do away with hierarchy because it's valuable. But, and I just made this slide up because in the beginning of doing this work, I got so much pushback about, well, what do you want us to all be? Like, we all have the same, say, and, do I have to take a vote in the operating room? Should I do this case? Should I approach this Zenkers externally or endoscopically? And, the most votes win? No, like, I'm in charge. I get to decide what we do. But it is not a hierarchy of respect. I don't care if you're sweeping the floors in the OR. You deserve the same amount of respect as I have, period. And I think that gets confused with people. Like, your role is, you have less importance in terms of responsibility, therefore you don't deserve the kind of respect and assumption that we're all here to do the work, to support the work together, okay? We have to just keep this in mind. Okay, so I hope I've made the argument that, we have what's called in business a burning platform, which means if we don't do something about it, things are going to blow up. So, the sense of urgency and importance based on, we know that this psychological safety impacts all of these domains, so that not supporting psychological safety actually costs. And this is what I want to say. The fear that if you hold Dr. D accountable and Dr. D will take their toys and go elsewhere, right, their RVUs and their grants or whatever, should be very much mitigated, if you will, counteracted by the fact that if you actually measure the ill effect that Dr. D and the like are having on these domains, you're hemorrhaging money by letting Dr. D behave this way. You are actually losing money. And one of the chapters in one of the books that this Stanford business professor wrote was called The Total Cost of Assholes. And he costs out what happens. Like, they're high rollers, right? They're bringing a lot of money, but people are leaving. That's costly. People are decreasing productivity. That's costly. They're hidden costs, right? But those who control resources really need to see, you think you're making money by letting Dr. D do this, you're losing money. Okay, so I'm going to try to now just answer the question, or just give some ideas, I should say, about how could we support psychological safety individually in teams and as an organization. So this is just my concept of, like, how do you build a program like this? How do you say organizationally, we care about this, we're going to think about this organizationally? So I think the first thing is leaders have to buy in. Like, this can't just be the grassroots. The leaders have to say, actually, this matters. And we're going to resource it. We're going to think about it. We're going to do things that will lead to culture change and supporting psychological safety. And so one of the ways I try to help organizations do it is to make sure the leaders buy in, like that this matters. It's not fluff. It is, it only matters if you care about patient safety, well-being, right? If you don't, then you're right, it doesn't matter. But who doesn't care about that? Okay, so I think also leaders themselves need to model. Dr. Mueller here is an expert in this, in what's called a growth mindset. The idea, what if we walked into the hospital, every single one of us walked into work, or virtually turned on our Zoom or turned on our computer and said, I wonder how I could be 1% better today. Just this idea of, like, I want to continue to learn and grow in whatever, any domain that has to do with my professional life, or my life period. That idea that I can improve and I want to improve, like this idea of improvement, learning and growth. It's very powerful because we all want to learn. Actually, that's shown to be a big motivator, and not just if you're an official learner. So we have to express fallibility. I tried to mini model it if I could in the beginning, saying, like, I might get something wrong here, right? Despite my best efforts, I might show a bias or something, and please let me know. If I get it wrong, I want to do the best I can for you. That you solicit as a leader and give. And by the way, as I said, we're all leaders in some capacity. It shouldn't be like, oh, this is just for the CEO, right? This is we're all leading in some way, and we need to think of ourselves as leaders. But so solicit feedback, say, help me, understand what am I doing that's working for you, and what am I doing that's you'd like me, maybe not to do that. Help me. I want to grow. I want to learn. Make speaking up safe, right? Help people do the right thing. So if you have people who are behaving in a way that undermines psychological safety, help them get motivated to change the behavior by understanding the impact it's having and by what your values are and how you want them to change. We have to hold ourselves and others accountable, and I think these are just some of the things that we can't just tell everybody else that you should act this way in support of psychological safety. We have to show that we are doing this. We're creating an environment in our meetings, in our choice of what we concentrate on, and in our daily interactions that are like, we're doing this behavior. This is who we are. So, Tu Gawande, so he and I were in the Department of Surgery at the Brigham for many years together. He's amazing. So he's done all this with, the checklist. What do you call that? Do you call it the checklist? Do you call it the timeout, safety pause? What do you call that where, the patient's asleep and it's run by? Timeout. Great. Okay. So, he built this, checklist, and it's amazing. He studied it. It turns out, by the way, it's not the doing of the checklist that correlates with safety. It's the attitude with which it's done. Right. So if I go, all right, let's go, and everyone knows I don't care about answering the checklist questions and I'm not paying attention to it anyway, you won't get good outcomes. But if the person, leading at the surgeon is like, we got to go through this. Let's have everybody's attention, that kind of thing. It matters. So one day I suggested to him, I was like, Atul, I have a great idea for something that I've been doing for years that I think you should add to the checklist. So I told him what it was. And I really literally used to do this in every case. So you're first of all, I make sure everybody is actually standing around the table, right? Not like just, you're at the computer, the right patient, but everybody's facing each other, and that we introduce ourselves, even if we think we know everybody there. There's often a new med student or somebody who's come in, but just, read for me. Here's, hi, Joe Shapiro, attending surgeon. So I'm the nurse anesthetist, whatever. You reintroduce yourselves, and then do the checklist, right? And I suggested adding this at the end of every single timeout. I just looked and I said, I just want to remind everybody here that this is a team effort. And that if you see anything that concerns you, I want you to speak out. I can't have my eyes on everything. None of us can do this alone. Please let us know if you see something you're concerned about. Now, why do I do that? Because don't you think I'm super approachable? I am. But now I'm not, just by virtue of my role, right? And so for me to actually encourage speaking out, I have to be explicit about it, giving everybody not just permission, but responsibility for we're part of this together. I can't do this alone. Nobody can do this alone. And so, he's like, oh, that's a great idea, Joe, but do you realize I've done all my studies with the checklist as it is, and I can't add it, but have fun with it yourself. So the point being, you can think of ways that you can set up psychological safety, encourage speaking out, without, how long did that take me? 30 seconds to do. I just did it as a habit, every single case. And you can do it in clinic, you can do it anywhere where you say, please let me know how things are going. I need to, this is so important that I get your feedback. And then there are other ways to do it, which is not if you see something concerning, but in addition to that, I used to do this at the end of every clinic session. I just would go up to the MA, anybody I was working with, and say, hey, let's talk about a couple things you think went well and a couple things you're like, that wasn't so great. And I'll share that too, so we can improve going forward. A routine, you're part of the team. We can make each other's work better. And part of that is honoring what went well. It's not just going over what did go well, because the best way people learn is to catch them doing something right, reinforce it, and you'll get better outcomes. And I'm biased. I'm an educator. I think people need skills. That's why one of the things I get asked to do more than anything in clinical leadership courses is to teach conflict management. We've got conflict. Conflict's fine. It's healthy. We want different views. We want different opinions, but it needs to be managed. And so let's teach people how to do that. You aren't born knowing how to do that. So I do spend a lot of time educating, working with people on giving critical feedback, managing conflict. How do you speak up, those sorts of things. So I'm a big one on education. I think especially we need to teach people how to speak up as a bystander for this reason. We've all seen things that are problematic and haven't said anything. I absolutely have, because it's asking a lot of the bystander. But that's why I think we need to teach people. We developed there's lots of ways to do this. I'm just, giving you an example of this, the skills training to teach. It was originally for residents. It could be for anybody, but they're going to be microaggressions. Let's teach people how to deal with them. And by the way, many of them are going to come from patients. So let's just be prepared. What do you say? Do you say anything in the moment? Do you talk about it afterwards? There's absolutely tons of different, really great ways to respond. But if you don't teach it, people don't respond. And then you have to have a parallel accountability program. Okay. You can't just go around telling everybody they have to act a certain way when everybody knows the high rollers are going to be excused. It's not fair, to say the least. And so you have to have an accountability program. There are lots of ways to do it. I'll just briefly share the principles of what we did. But I think the idea is the leadership has to be committed to it. They can't be like everybody but these people has to support psychological safety. And I want to be really clear. I am not talking about minor stuff on occasion. Okay, if I roll my eyes once a year, twice a year, I hope you forgive me. It's not great, but come on, people. I'm not talking about that. I'm talking about where the person has a pattern of behaving that way so that people are then wary of speaking up, for example. Okay, so patterns, right? Or obviously single incident egregious. And I think you have to have a safe way to report concerns so that the idea is you can help the person get better, not so you can be like, I'm going to punish you. The idea is take people who are struggling to do that, to behave in a way that supports psychological safety and help them do a better job, right? It shouldn't be the goal of the system to punish. Not that that won't have to happen sometimes, but that should not be the stance, right? It has to protect the people reporting concerns, and it has to be fair to the person about whom concerns are reported. Because in our experience, not a lot, but on occasion, the actual reports were completely invalid. When I say reports, I have people coming to me and saying what the behavior was. Then we did this validation where I would multi-source interview without using names, just saying, have you noticed it? And on occasion, very rarely, but not never, it turns out that was a bogus concern. Most concerns are validated, but they have to be validated. You can't assume that what the reporter says is true, right? And you say that, like, that sounds terrible. I need to do some assessment. I have your permission to do that without using your name. And I really feel strongly about this, though I don't have a study to support it. I do have an opinion piece that I was involved in writing. I believe that most online safety reporting systems are misused. And this is why we called it gotcha. It is often used by one group to get another group in trouble, another person from a person from another group, right? And I think it's a terrible way to try to work out interpersonal conflict, to report, especially if you allow anonymous reports. You really can't get to the bottom of the conflict, and it's very hard to make improvements in relational stuff with online safety reporting. And I just think it doesn't work well. So I think it needs to be a relational, safe way to report concerns where that all those other domains are there, that they're treated fairly, and the person about whom concerns is also treated fairly. And I want to say this, and to just not get a culture where people are snitches, right? So this is why I call be careful what you ask for. We're not talking about perfection. Every little thing has to be reported. That's just garbage and a waste of everybody's time. It shouldn't be like, we shouldn't valorize, just reporting where there's been no attempt to actually make things better with that person, right? You may need help. You don't want to talk to that person yourself because you're afraid for some reason, but reporting them like through, as a safety lapse, it's just, I think it's bad. And also I want to say this, here's my thought. Sometimes the bad behavior for physicians in particular comes out of immense frustration with performance deficiencies, right? Or resource deficiencies. So if I am, let's say in the operating room, and I am, each time I have, this scrub tech that I work with, that I have been assigned to this day is, just really doesn't know what they're doing, right? And I have no way to make that known, to think about improvement for that person to improve. It's going to be hard not to let little bad things come out of my mouth. And I think one of the problems that we have in the way we've organized things is we don't sit and talk about performance improvement as a multidisciplinary group. And what if after every case, or even if we did it, as a group once a week or once a month or once a quarter, sitting down with the relevant people saying, what are some of the themes? What are we doing well as a team here in the operating room? And where could we do better? That it would be expected and people would value that. And it wouldn't be like, you messed up and no, it was him or they did this. It would be like, of course we're going to do that, because that's how you improve, by reflecting on what you did and doing more of the good stuff next time and less of the bad stuff, right? But we don't have those conversations. We just don't. We have no process for having them, but we could. We absolutely could. Okay, so I really think it's not like we should be tolerating performance deficiencies, but how do you make people aware of them and so that they can improve? And then you have to escalate if people continue to do the behaviors that undermine psychological safety. They do need to have consequences. So last thing I want to say is I did some work in Australia for an academic medical center. They wanted to do like a big professionalism psychological safety thing. So my husband came with me to Australia, and we decided we got to go to Sydney. And so when we went to Sydney, what did we have to see? Opera House, obviously. And we did, and it's amazing. But there was a construction site on the plaza there with the steps, and there was a big bulletin board for the construction team. And I kind of wandered over and I took a picture of it because you'll see why. I will do everything I can to go home safe. Never forget rule number 1, respect my workmates, communicate positively with those around me, challenge my mates to do the right thing, present fit for duty and ready to do my best, never take shortcuts at the expense of safety, lead by example and be proud of my work, speak up if I see something not quite right, step up and help my workmates if I see they need help. And I thought, that's who we are. That is who we are. We can do this, we do this. Those are really, it's a like sort of wonderful touchstones. So I've seen the results of that tremendous faith in our ability to really work well together. We just need to think about how we can structure things so that those conversations happen, and they happen in a way that that we are remembering we're on the same team. It isn't us versus them. It's us to improve patient care, to improve learning, to do better research. We need to remember that, but we need to structure our processes that support that we are interdependent in the most lovely way. So thank you for inviting me, and I'm happy to have not just questions, but how did this land for you? I would love to hear any of your feedback. Thank you.